Good morning, ladies and gentlemen. As all of you know, that thank you for to welcome. Say Mice Ideas and welcome Technology Group. Rajesh Sharma, Mr. Yash Agarwal, the Committee of and all for last extremely right top you need to put in your question. We have again a so pregnancy feedback. So you have the again feedback to at the right top. So if you need this for any today, we have none other than Professor Dr. Tulika and Dr. Fazia. I'd like to introduce you to our future webinars during this month. Department of Medical This third child is this myself from next weekend, that is 19th of July. We have the webinar on measurable residual disease. And the chair for that is none other than Lieutenant General Dr. Velu Nair from Delhi. Speakers together with me is Dr. Amita Mahajan and Dr. Jyoti Kotwal. 26 advances. So that we have two personalities from Tata Hospital, Mumbai. There is Dr. Bhausai Bagal, one personality, I'm sorry. And Dr. Rayaz Ahmed from Rajiv Gandhi Cancer Hospital, Delhi. And then we have international speaker Dr. Niranjan Rathod from New Zealand. Free to contact ID and the mobile number, you can WhatsApp him. 60 from now to our aims.
I hope I'm audible.
Yes, ma'am.
Okay. Speakers covering all the important topics in pediatric leukemias. The first speaker who I'm very honored to invite is Dr. Gauri Kapoor. She is Director of Pediatric Hematology Oncology at Rajiv Gandhi Cancer Institute and Research Center at Delhi. She's also been the past chair of the PHO chapter of IAP, and I saw on her introductory slide, she's also the medical director of the Nitibag branch of the Rajiv Gandhi Cancer Institute. And she will be talking on the very important topic of acute myeloid leukemia in pediatrics. So it's my honor to invite you. Please go ahead.
Thank you, Dr. Tulika.
No issues. Let me load your presentation, ma'am. No issues.
For a minute. Give me a minute. Slides?
I will, ma'am. No issues. You just give me the next. I will forward it.
And can you just give me a minute? I would prefer to use my own slides so that I can move it at my will. It will be easier for me. I am not that. So slide share, why is the slide share? Let's see, open this. Slide share. Just tell me, can you see the slide? It is just having a small bar. The whole slide is not opening up.
No, you have to select your presentation window, ma'am. Yes,
okay.
Now it's coming.
I opened my presentation. Yeah. And I am on PowerPoint. Are you able to see my slides?
No, it's loading, ma'am. I think so. Now we can see your slide. Yes, now please go ahead, ma'am.
Wonderful. Thank you so much. So thank you, Dr. Tulika and Dr. M.B. Agarwal for giving me this opportunity to discuss pediatric AML, how I treat. So as you are all aware, pediatric acute myeloid leukemias constitute just 15 to 20% of all leukemias. And as you can see here, 50% of the deaths of acute leukemias are because of acute myeloid leukemia. It is a heterogeneous group of diseases, and it is constituted by not only the myeloid lineage but the erythroid, megakaryocytic, as well as the monocytic lineages. There are certain interesting predisposing syndromes associated with acute myeloid leukemia, which you should, as students, know very well: Downs, Fanconi's, DKC, Klinefelter, Bloom's, etc. And there are certain acquired conditions like aplastic anemia and PNH, which could clonally evolve into AML. So we must, in our clinical practice, be aware that children who have any of these syndromes or any of these conditions may develop AML at certain point during their childhood. So moving on, what is the progress? We all know ALL has made fantastic progress. What about AML? So as you can see here, in the last 5 decades, the improvement in survival of acute myeloid leukemias has occurred from less than 20% to about 65 to 70%. So approximately 40% improvement in survival, but nowhere where we would like to be for pediatric leukemia. If you look at this graph here, you can easily see that over a period of 4 or 5 decades, the number of patients. Hello.
Sorry, ma'am, your slide went off, ma'am.
Can you see it now?
No, ma'am. You have to do again slides here.
Okay.
Yes, ma'am. Please go ahead.
So as we can see in this graph, over the last 40 to 50 years, the survival of AML has improved from 15% to 65%. So what has contributed here? Contributed here, you can see here in this graph here, colored graph, you can very nicely see that the remission, alive in remission rates have improved about 5 to 10%. The survival after relapse has improved another 5 to 10%. However, the toxic deaths have reduced by about 15%, if you see very nicely. So all of these together have contributed. The drugs have not changed very much. However, there have been incremental improvements due to better risk stratification, due to better supportive care, and definitely because of fine-tuning the exact role and place for hematopoietic stem cell transplantation. So as I was saying, the 2 most important or critical decision points are appropriate risk stratification, which is based on genetic, molecular, and certain factors of the disease, and the response to treatment. And the other major player is the improvement in supportive care. So I'm showing you in this table the conventional risk stratification for acute myeloid leukemia, which we have been following for the last almost 2 decades. 821 translocations in version 16, and these constitute the rungs translocation, which constitute about 30% and have had a good overall survival. Then the poor risk or high risk are those with 5-7 translocation constituting and complex karyotype, as well as those who do not have remission after first induction. And these had a poor survival. The rest were all thrown into a basket called intermediate risk, which constitute nearly 50% of cases with a 50% survival. Now, if we further go, so about 50%, we were not able to identify any chromosomal abnormality, and therefore they were called intermediate risk. Now, if we see further, what we see here is out of these 50%, almost 20%, which were called normal, have now, with the detailed molecular typing using NGS techniques and other molecular techniques, we know that 23% of these children have the NPM mutation, 18% have FLT3 internal tandem duplication, and around 14% have SEBPA. And these three groups actually have a very apparent prognostic implication. Very, very apparent. So they have now come into the risk stratification. Further, if you see, these have been incorporated in the AML WHO classification 2016 as well. So it is very important for a student of hematology to know this classification. And in this, as you will see, certain recurrent genetic abnormalities have been added in addition to 821 and inversion 16. PML RARA, as you know, we do not treat like other AML, so they are no longer in the risk stratification. But you can see 9, 11, 6, 9, inversion 3, they have been included in the WHO classification. And also you see below the provisional entity, AML with BCR-ABL, NPM1, SEBPA. So all of these have now entered the WHO classification, and that has been very, very important. Also, AML with Downs, AML with MDS, therapy-related AML are now separately categorized. So after that initial phase, we now started classifying AML as low, intermediate, and high risk, and the low risk included, other than 821 inversion 16, the mutated SEBPA, that biallelic mutation of SEBPA, mutated NPM1, both of them without the presence of FLT3 ITD. So these were low risk not requiring transplant. The high risk now included the FLT3 ITD, the MDS AML, the therapy-related AML, the megakaryoblast AMLs without 122, and 6, 9, 8, 16, and 1621 translocations, in addition to monosomy 7 and 5 or deletions of 7 and 5. So these were the three groups. So I will share with you the COG AML 531 data. And if you see here very nicely that along with this genetic and molecular information, they have added the MRD data and looked at their data retrospectively. So what MRD data have they looked at? They have looked at the end of induction MRD, right? And when they looked at the data, in which they have included not only the translocations, but also the genetic data, and when they have added the MRD data, they found that amongst patients with intermediate risk AML, the MRD end of induction being negative made the intermediate risk patients having a 65% survival or disease-free, relapse-free survival, which was equivalent to that of good risk patients. So the intermediate risk MRD negative end of induction did so well that they did as well as the low risk patients. So the most important finding of these analyses was that the prognostic value of MRD was very important for intermediate risk or standard risk, as the call it, the standard risk AML. So if you see here, for patients with good risk, it didn't matter. For high risk, in any case, MRD is positive end of induction, outcome was zero, right? So what they did is, for the future proposed risk classification, they used the molecular data. They did a provisional risk stratification. They added the end of induction MRD, and the standard risk or intermediate risk patients then have been decided. They have planned to move them as low risk or high risk based on end of induction MRD. So end of induction MRD negative became low risk, and if it was positive, these became high risk. So if you move from here, these are the graphs of the data. So you see here the standard risk initially constituted 59%, but now then moved to 33, and finally 60% are low risk, 40% are high risk. Low risk included the standard risk MRD negative end of induction patients. So in their subsequent studies, they are now going to use this two group classification for risk stratification of AML, which would include end of induction MRD. So MRD, very important now. We know that for ALL, we've been using MRD for more than 5 years, almost 8 years now, and it has been very useful for us. Now for AML also, we are using MRD to decide the treatment after induction. And this is a detailed graph the COG has proposed. As you can see, there is just two groups, high risk and low risk, and standard risk patients who MRD negative end of induction would also be considered as low risk, because the important thing is to transplant or not, so they would not require transplant. So I would quickly go now over to discussing 2 or 3 cases so that you will have an idea how to proceed for our patients with AML. So a 6-year-old boy presented to us with fever, fatigue, dizziness, and leg pain for 10 days. A hemogram revealed that he had a low hemoglobin, thrombocytopenia, and a WBC count of 9,200 with 80% blasts. The marrow revealed presence of all rods and certain dysplastic granules. Further workup now we would do for all patients a karyotype and for all patients molecular profiling. So the flow clearly showed it was a CD13-33 positive, AML, NPO positive, and the cytogenetic evaluation revealed translocation age 21. And the molecular profiling confirmed the same. And you can see here in this pictograph that there are all rods present. You can see in these blasts, large blasts with a good amount of cytoplasm. You can see an all rod, and these blasts were also showing features of some amount of dysplasia in the granulocytic series. So it is not an MDS, it is a AML A21, which, as we have discussed, all of these are favorable cytogenetics, right? So it is a favorable cytogenetic, and the studies from MRC, from BFM, from St. Jude trials have shown they have excellent survival. Right, so how do we plan for them? We have planned 2 cycles of induction and 2 cycles of transplant, and we are not going to do any bone marrow transplant for 2 cycles. 2 cycles of induction, 2 of consolidation, and no role of BMT in these patients. So what induction do we use? So after we admit the patient, stabilize the patient, start him on some fluids, antibiotics. The patient had low-grade fever, so we start after sending cultures, start the antibiotics. Child looks good, we start induction. So there was no evidence of any tumor lysis. So we used 2-drug induction, which has Dono at 50 per meter square, day 1, 3, and 5. It has Ara-C at 100 per meter square. Patient is admitted. All new patients induction are admitted for their first cycle of chemo. And we also give intrathecal on with first and second induction, which is triple intrathecal. Our antibiotic that we use as first line is cefoperazone sulbactam, and after they complete their first cycle of induction, even whether they have fever or not, we start them on antifungal prophylaxis with oral voriconazole. If they have a lot of hectic fever, we do a chest CT, which was normal in this child. This child was hospitalized for the entire first admission because he had intermittent fever throughout, but there was no culture positivity. So when we did it was not non-turbulent, the course. He had intermittent low-grade fever, intermittent high-grade fever, and it responded whenever we changed the antibiotic. Cultures were always negative. Day 28 marrow was in remission and MRD was 0.6. So after the first induction, we proceeded to the second induction, which we used donocytarabine, and then the child received 2 cycles of consolidation. We use CLASP, which is high dose Ara-C with L-asparaginase, day 1, day 2, and then day 8, day 9. He completed treatment 4 years ago, is disease-free, and is following up disease-free for last 40 years. So now I would like to discuss with you about the options for induction and what studies have shown in the past 2 or 3 decades. So one is that we clearly know that high dose RRC is very effective for AML. But when it was used, should we use low dose or high dose? This controversy is there in induction. So people have tried various options, 3 grams per meter square versus 100 per meter square, and they found that definitely the deeper remission was achieved with RRC 3 grams per meter square, but this was more toxic. And because the overall survival was similar, therefore we have continued with the low dose. Most trials show that dose effect exists for high dose RRC. It improves depth of remission, but there is definitely better equal outcome because it is quite toxic and induction toxicity was high. So I will share with you the results of certain recent clinical trials for pediatric AML over here in this slide. And as you can see here, high dose RRC was tried quite in the early 2000s and 90s, and they found it was definitely beneficial, but it was more toxic when used in, and it was a definite component of consolidation therapy. Definitely it was effective strategy. When they tried, so you have seen the AML, the St. Jude trial, and people have shown, the Australian group have shown, many people have shown it is definitely good. So what about number of drugs during induction and type of anthracycline? So people have tried daunorubicin, people have tried mitoxantrone, they have tried idarubicin. More or less the results are similar. So we have stuck with daunorubicin. I will give you a few slides that. Another interesting thing was that growth factor during induction did not decrease the incidence of infection-related mortality. So this is the choice of anthracycline, idarubicin versus dono. So what did it show? We used 60 per meter square. I will show you the doses over there, 60 per meter square versus 12 per meter square of IDAR. So the 5-year EFS was similar, but the cell clearance at day 15, blast clearance at day 15 was definitely better with idarubicin. But again, it was more toxic. Long-term survival was more or less similar. You can see here, it was slightly better for the idarubicin arm. We have to think of 2 things, the cost of idarubicin as well as the toxicity. Do we have the supportive care to manage these children? What about 2 drugs versus 3 drug induction? In adult studies, they've always used 3+7. In pediatric studies, most trials have been using 3 drugs and either etoposide or 6-TG. And very clearly, data didn't show, and prior to AML 15, people in pediatric trials were always using 3 drugs. They said the depth of remission and long-term survival was better. All the CR rates were similar. However, it was only the MRC 15 where they actually did a head-to-head trial and showed that CR rates and long-term outcomes, relapse-free survival, deaths in remission, and OS were quite similar with both strategies. So we have now convinced the pediatric oncologists and the pediatric hematologists also that 2 drug induction is good enough and we can manage without adding the 3rd drug. Whatever you may say, adding the 3rd drug definitely contributes to some amount of additional toxicity because the recovery takes, myelorecovery takes longer. So this is another thing. So 65% is what we have in overall survival, event-free survival. So can we push the dose of dono? People tried liposomal dono, and this trial again shows that giving 80 per meter square liposomal daunorubicin doesn't really add anything to the outcomes. So we are again with 2 drugs with a dose which is standard dose. What about gemtuzumab? I will show you gemtuzumab came early, but in 2000, but it was withdrawn in 2010 because there was a higher treatment-related mortality, and the way we were using the drug didn't really benefit the patients. But in 2017, it has again got FDA approval, right? And these are the various trials, MRC, SWOG, MCRI, Alpha, and others, who have shown not much change. But a meta-analysis, a recent meta-analysis has shown that in the good risk patients using GO, 77% versus 55% overall survival was seen. And on the basis of this, we have now trials in pediatric AML where they are using gemtuzumab during induction, and it has seemed to be benefiting the good risk patients, pushing their event-free survival much higher in the range that we would like. So to summarize, dose of anthracycline, dose standard, 100 per square of Ara-C, donor 50 per square equal to IDAR mitoxantrone. Addition of third drug doesn't really add anything. Moving on to consolidation. So clearly, these meta-analyses have shown that it is a good strategy, but using in pediatric AML, using high-dose Ara-C alone for AML is good in only for the good risk patients. For the high-risk patients, we need to add another anthracycline, and mitoxantrone studies have shown high-dose Ara-C with mitoxantrone definitely improves the disease-free survival for AML. You can see here the results of the BFM93 showing survival of 44% versus 31%. What about 4 versus 5 cohorts? Now the data again is a little controversial, but it has been seen that it depends how intensive is your induction and how intensive should be your consolidation. If you have an intensive induction and you have an intensive consolidation, 4 cycles may be adequate, especially for the low risk and intermediate risk. For high risk, in-vet transplant is required. Right? So even the COG studies show high-dose Ara-C 4 cycles good enough for good risk patients. For maintenance, DFM have used it, but there is no consistent, nobody has replicated the data. And if you see actually the summary of post-remission therapy, good risk patients, high-dose Ara-C is good enough consolidation. For intermediate and high risk, and anthracycline should be added to the high-dose Ara-C. Maintenance has not been shown to be beneficial, and 4 courses almost equal to 5 courses, but it depends how intensive is your 4 cycle. Are you using clasp, are you using hand, or are you just using high-dose Ara-C? So one has to be careful about it. Moving on, therefore, to the next case, a 15-year-old girl presents with weakness, bruising, and bleeding from gums for 1 week, found to have hyperleukocytosis, thrombocytopenia. Marrow shows monoblastic morphology of blasts. The karyotype was normal, but the molecular workup shows that there is wild-type FLT3 and there is 2 mutations of CELPLG. Coming to the clinical management of this patient, and I will say that it's really important for these patients to they have very close monitoring, good supportive care. Hyperleukocytosis has to be managed as an oncologic emergency because these patients have risk of pulmonary and renal compromise, intracranial hemorrhage, secondary to leukostasis. But also when you start anti-leukemia therapy, especially with cytarabine type of drug, there is chance of systemic inflammatory response, so they can become very sick very quickly. So we want to reduce the counts quickly. Usually, as we are sure of the diagnosis, we start hydroxyurea. If we think it's a monoblastic, myelomonoblastic, we have to see if leukophoresis is required or not. We start tumor lysis prophylaxis, but at the same time, we have to keep an eye that there is rapid tumor lysis with start of low-dose cytarabine. We may need to use some dose of methyl prednisolone, which is recommended 0.5 to 1 milligram per kg. So again, in a nutshell, supportive care for these patients is very, very important. This may be a lower intermediate risk patient, It may be intermediate risk, maybe, but first week we have to manage with AML. So we started with hydroxyurea. Patient was stable. Then we started low dose Ara-C, and we also gave a little bit of steroids so that the inflammatory response would be manageable. Because if they have cardiac compromise, they have hemorrhage intracranial, these patients can be lost very quickly. So patient tolerated first induction well, had certain bacterial infections which were controlled, received voriconazole prophylaxis, and then achieved remission after first induction, then went on to receive second induction and consolidation with CLASP and HAM. Here I have written HIDAC versus HAM because high-dose Ara-C, sometimes mitoxantrone is not available, we have to go for high-dose Ara-C alone. Because if the SEBPA mutation was not there and an allogenic donor is available, these patients after dono Ara-C induction and one more chemo would be eligible for allogenic BMT. So 14-year-old, third case, I want to just tell you, this patient had FLT3 ITD and the allele ratio was more than 0.5. And so the question is, this patient definitely good after induction and one more cycle of chemo must go for allogenic BMT whatsoever donor we can. So these are clearly those. Now if we look at the details for transplant and role of transplant in AML, what is the data? There was a time when we used to do induction and put these patients, if the sibling was there, they would go for transplant. All patients of AML pediatric used to go for transplant. But we have realized now with more molecular data, cytogenetic data, that good risk patients do not benefit. The survival is good enough without transplant. So where is the role of transplant? You can see here there was a time when the toxicity was so high that certain trials stopped doing transplant for AML and CR1. They kept it only for CR2 patients, right? So these consistently, then they stopped. But now what is it? Now we have realized which are the patients who will benefit from allogenic BMT. So these patients who will benefit are the ones clearly who are high risk and the intermediate risk who are MRD positive. But we also know that prior to transplant, if the MRD is negative, the long-term outcome will be good. So we should try to achieve MRD negativity before transplant. So in a nutshell, which are the patients who will benefit from allotransplant? Good risk and downs don't require. Intermediate and high risk with more refined risk stratification we correctly identify. Especially, like I said, FLT3 positive, those who are MRD positive after the first and second induction. We should try to intensify chemo, get MRD negative and go for allotransplant. MRD negative pre-transplant is desirable. CR2, everybody will go for transplant, and non-TBI based conditioning naturally for children is preferable. What about FLT3? So we have also realized pushing chemo doses, pushing more chemo is not the answer. We need novel agents to get the survival up there for AML patients. So we have now targetable molecular abnormalities, one such as FLT3 ITD, and Misenchi et al. Have clearly shown that a ratio of more than 0.5 is a powerful and independent negative prognostic factor with the progression-free survival only 16%. In children, we don't have trials, but adults are using it. Midostaurin, which is a FLT3 inhibitor, is now combined with induction. And you can see here that they have combined after finishing donocyte 3 plus 7, 8 to 21, they are starting this. Right? For children, what are the novel agents people have been working with? The investigators have been for FLT3. Everybody knows it's a bad prognosis. They have been trying bortezomib and sorafenib in the various trials. We still don't have their results. But clearly, the drug I just showed you, midostaurin, is something which is really promising. And if I show you this slide, it will show you here. In 70s, we started AML treatment, where 3 plus 7 became standard protocol. Transplant came in late 70s and 80s. Mylotarg came in 2000 and then disappeared in 2010 because of controversial toxicities. In 2017, Mylotarg is back for CD33 positive AML, but it has been now seen to be beneficial for the good risk patients. What about other mutations? FLT3, you have seen midostaurin, IDH2 mutant and relapsed refractory. People are using newer agents here. Unfit elderly, people are trying more agents, venetoclax, lasdegib. So many drugs are there. So in pediatrics, I think we have to learn and wait and watch the adult results. Whatever is promising, we are trying to use it in pediatric trials. So for AML, if we conclude 65% of children with AML now survive, it is because of better risk stratification. It is because of optimization of chemotherapy, of accurately defining the role of stem cell transplant so that we give toxic treatments to only those children who require it. There has been tremendous improvement in supportive care, better blood product availability, plus much better antifungals. Further improvements are unlikely with conventional chemo, therefore it's an exciting time for AML. Lot of targetable, druggable targets are now being discovered. There's a need for newer agents and for targeted therapy. We will see how the next few years show us the results of the trials which are going on in the various groups. Thank you, and I would like to acknowledge my entire team and especially Dr. Sandeep Jain for allowing me to borrow some of his slides. Thank you.
Thank you, Dr. Gauri. That was an excellent overview of pediatric AML, and your experience was very valuable. We are going to take the questions at the end of all of the three talks. So we now move on to the next speaker for this, who will be Dr. Fauzia N.A. Dr. Fauzia is a consultant in pediatric hematology in the Department of Hematology at CMC Vellore. And today she will be talking about the very important topic of pediatric acute lymphoblastic leukemia. And she will be talking about what is new in 2020. Thank you, Dr. Fauzia.
Thank you, ma'am. Am I audible?
Yes.
First of all, I thank Dr. M.B. Agarwal and Dr. Tulika for making me part of this program. So I will be speaking on pediatric acute lymphoblastic leukemia, what is new in 2020. So the outline of my talk will be like lessons in risk stratification, using medications more efficiently, reducing toxicity, MRD-directed therapy, and advances in T-cell leukemia and immunotherapy. So I'll start my session with a quote from Ori Woodward, which is like, success is the exponential effect of little things done consistently over time. That is what exactly has happened in the management of pediatric acute lymphoblastic leukemia. So over the past 5 decades, there has been tremendous improvement in the survival of childhood ALL, with survival rates now exceeding more than 90%. So this table shows that selected clinical trials showing progressive improvement in the survival over the years. And this survival has been possible with several randomized controlled trials which tried the intensification and CNS-directed therapy, which further improved the outcome in the high-risk group of patients. But basically, no new drugs were added in the last 3 to 4 decades. So this outcome improvement have been attributed to the number of different factors that include the delivery of multiple chemotherapy agents to prevent drug resistance, the recognition that sanctuary sites, especially CNS, need focused treatment, and also the identification of risk group and diagnosis and early treatment response to determine the appropriate intensification therapy. So coming to the risk prognostic factors in childhood ALL. Some of the key factors for risk assessment are the National Cancer Institute risk group based on age, that is between 1 to 10 years, and the WBC count of less than 50,000 diagnoses, and which characterize them into high risk. The other risk characters are the immunophenotype, that is the T-cell ALL which has got adverse risk. As per this NCI risk group, High-risk group of patients have a 5-year event-free survival of 50%. However, this identifies only 20% of the patients destined for relapse, suggesting that this categorization alone does not translate to treatment outcome. So, although outcomes of the overall children with ALL have been quite good and have continued to improve over time, this has not been the scenario when children at the end of the age spectrum is considered. So here you can see the outcomes for infants less than 1 year of age are clearly inferior as well as those for the adolescents and young adults. This is mainly because the infants ALL, they belong to a category with MLL rearrangement, which has got more dismal outcome. Although small studies suggested that stem cell transplant improved outcome in this group of patients, there are large cohort studies which failed to show significant disease-free survival or overall survival in this group of patients. So the Indefin 99, which is the largest group which has studied the infant ALL, show that a very high risk group of infants, that is aged below 6 months and either poor progesterone response or with an initial WBC count of more than 3 lakh, this group benefited from allogeneic stem cell transplantation. That is a 64% reduction in risk of relapse or death in remission. With mismatched donor transplant, the outcome was found to be very inferior compared to chemotherapy alone in this group of patients. So come to the molecular and cytogenetic subgroup in childhood ALL. So this table shows the clinical impact. So this shows the different risk categorization cytogenetics into good, intermediate, and high risk. And the pie chart shows the breakdown of the common cytogenetics and molecular findings in ALL. As you can see that about 50% of the children have genetic changes associated with favorable outcome, that is high hyperdiploidy or the presence of translocation 2021. In contrast, relatively rarely, children will have unfavorable genetic features. So hypodiploidy with less than 44 chromosomes, MLL rearrangement, BCR ABL translocations, PH like ALL, and CRLF2 rearrangement and intrachromosomal amplification of chromosome 21 are associated with high risk features and poor outcome. And other alterations or molecular markers like the IKZF1, which encodes the lymphoid transcription factor Icaros, are common in the pH positive and pH like ALL, and these are also associated with poor outcome. And this table shows the poor outcome of the patients with high risk category. So identifying this group of patients is important to intensify treatment and thereby to enhance the survival in this group of patients. Here we can see how does the cytogenetics and molecular characterization impact the treatment of the leukemia. So this table shows the clinical impact of cytogenetics on the B-cell ALL and the 5-year event-free survival in this categories. There are several studies have shown that patients with hyperdiploidy and trisomies 4 and 10, they have excellent response to the antimetabolite-based therapy. Those with 12-21 translocation, they have been found to express myeloid-associated antigens, and they have been found to have excellent prognosis with intensification with asparaginase-based therapy. And those with translocation 11-19 are found to have increased risk of CNS relapse. So this group of patients do well when high-dose methotrexate-based regimen is added. The patients with MLL rearrangement, especially with the infant groups, they do, that we have already discussed, they do badly with the conventional chemotherapy. So, and identifying other categories like BCR, ABL, and the pH like AML helps in adding tyrosine kinase, targeted molecular therapy like tyrosine kinase inhibitors, which can improve the outcome in this group. So, coming to the molecular subtypes, pH like ALL. The pH like ALL is constitute about 15 to 20% of high risk ALL in children and 20 to 40% in adults. So the genetic alterations which activates kinase signaling. These are more common in males, and they usually have higher WBC count at presentation, and they have high rate of MRD positivity and relapse with conventional chemo. So here you can see the survival of patients, non-pH like patients is very much, the pH like patients very less compared to the non-pH like patients. So most commonly, the individuals with the pH like ALL have rearrangements in a gene called the CRLF2. So about more than 50% of the patients with Pedriatic AML have rearrangement in this category. Other subtypes involve the ABL plus alterations, JAK2 and APO rearrangements, and other JAK-STAT signaling pathway abnormalities as well as RAS pathway abnormalities. So despite the genetic diversity in PH-like AML, majority of these cases have alterations that converge to the two common pathways, that's the ABL class pathway and the JAK-STAT signaling pathway. So dramatic improvements in survival over the past 50 years is because of the identification of the most effective doses and schedules chemotherapeutic agents. And subtypes with target molecular lesions have identification of subtypes with target molecular lesions have paved way for the use of precision medicine approaches to cancer. Examples of Ph positive ALL, where the addition of imatinib to conventional chemo have minimized the need for transplant in CR1. You can see the disease-free survival when imatinib was added to the conventional chemo, was 7-year disease-free survival was 71 compared to 21% with chemo alone. Same way, when imatinib chemo was used, this has had almost similar survival when compared to the related as well as the unrelated transplants. PH-like ALL have got poor prognosis and they are also candidates for individualized TKI. Individualized tyrosine kinase inhibitors. And the type of tyrosine kinase inhibitors which are found to be effective in PH-like basal AML are ruxolitinib, dasatinib, crizotinib, based on the type of rearrangement they have. Coming to T-cell ALL, T-cell ALL has got a very poor prognosis and aggressive nature, and with intensified treatment, there has been significant improvement in this group of children, which is equivalent to the T-cell ALL, that is more than 90%. There are no prognostic clinical variables or genetic alterations in other than MRD in T-cell ALL at present. So the risk stratification of T-cell ALL is limited to MRD and the morphology of the bone marrow at the end of treatment. So large percentage of patients with T-cell AML are found to have detectable MRD at end induction, but outcome favorable is favorable if low or undetectable MRD is noted at the end of consultation, that is 3 months. So in this group of patients, CNS relapses occur more frequently. So CNS directed systemic chemotherapy is recommended in this group of patients. With CNS directed therapy with cathepsin methotrexate, L-asparagine, and neloramide therapy. ETP ALL is a subset of T-cell ALL which has got genetic alteration distinct from the non-ETP ALL. They have similarity to myeloid leukemias or the T-myeloid mixed phenotypic acute leukemias. So they have a prognosis similar to non-ETP ALL. So the diagnosis of ETP ALL per se is not an indication for transplant. They are often corticosteroid resistant and they are found to have high percentage of detectable MRD on day 29 and induction failures. So coming to the topic how drugs can be used more effectively. So with all this intensification of treatment, although we have been able to improve the survival of these patients, this is at the cost of increased long-term and short-term toxicities. So coming to the use of prednisolone versus dexamethasone in induction, there has been a lot of randomized trials looking at the advantage of prednisolone versus dexamethasone. And this is a randomized trial from the BFM ALL 2000 group. After 7-day prednisolone pre-phase, randomly the patients were selected to receive either dexamethasone 10 mg per meter square, prednisolone 60 per meter square for 3 weeks with tapering in induction. The 5-year event-free survival was found to be better with dexamethasone. However, there was no difference in the 5-year overall survival. And the T-cell ALL with good prednisolone response were found to have significant survival benefit, that is 91 versus 82%. But in B-cell ALL and good prednisolone response, they had worse survival when this patient relapsed. So this explains the lack of benefit from Dexa in overall survival that we observed in the total cohort, except in the subset of T-cell ALL patients with good prednisolone response. So the replacement of prednisolone by Dexa is recommended only in T-cell ALL. Coming to the use of PEG asparaginase, what is the advantage over the conventional? asparaginase have high circulating half-life. They have increased water solubility, and there is limiting adverse immunological effects. They're more stable over a range of pH and temperature changes, and they have fewer adverse reactions. So the COG protocol for standard risk ALL have added asparaginase to the regular protocol, that is 2,500 units per meter square on day 4 of induction and day 4 of delayed intensification. And all doses are given as 2-hour IV infusion. In the high risk group, there are total 5 doses, 1 dose on day 4 of induction, 2 on consolidation day 15 and 43, and 2 doses in delayed intensification day 4 and day 43. So how to improved survival with the intensified treatment, the other significant side effect is the late complications. So why is it important not to overtreat ALL? As cure rates for childhood ALL has improved, the treatment-related death has been found to be higher. Around 1 to 2% of ALL die before remission due to the treatment-related toxicities, and 1 to 2% die from toxic effects during remission. So our certain group of patients like Down syndrome, older teenagers, and those receiving more intensive treatment, the risk of death from toxicity and infection is high. So in this group of patients, the amount and the duration of the drug given has to be reduced. And this risk can be mitigated by modification to therapy and supportive care. And in a study by the US Cancer Survivor Study on 15,000 childhood cancer survivors showed that around 69% of the ALL survivors had a serious chronic health condition at about 30 years of age. So defining quality of survival is essential in this group of patients because these people are going for treatment on a long-term basis. So the other way of reducing the long-term complication is limiting the exposure to toxic drugs. The UK and the US study groups have limited exposure to anthracyclines in induction to only the high-risk patients. This is to reduce the depth and duration of the bone marrow failure, mucositis, and late cardiotoxicity. And in patients with Down syndrome in UK, even in the high-risk patients, they start on 3-drug induction without anthracycline. And anthracycline is added after day 15 for those with slow early response. And thiaguanine, although it has been found to be more effective than 6-MP at preventing CNS relapse, it has been replaced by 6-MP because of the increased risk of death in remission and BOD of the liver. And the other complication that happens is the osteonecrosis, which can be reduced by reducing the Dexa dose to alternate week in intensification. So the other question is there a need for BCR prednisolone in maintenance? Several systematic and randomized trials have been done on this, and it has been found that for intermediate risk patients treated according to the BFM protocol, pulse steroid should become a standard component of therapy. And this group of patients, even though overall survival is the same, there is an advantage over the disease-free survival in this group of patients. The other point to be considered is regarding de-escalation of treatment in low-risk patients to reduce the treatment-related complications. 2 recent trials by the UK and the Dutch have found modest de-escalation of treatment as feasible for MRD-defined low-risk group. But contemporary European studies have found that increased relapse risk is found to be associated with this de-escalation. But so all the treatment groups will de-escalate therapy in children with Down syndrome because of the treatment-related mortality in these patients. So the other side effect that happens, especially when people are on long-term 6-MP, is that certain group of patients who have polymorphism TPMT and NUDT15 polymorphism, they're found to be oversensitive to 6-MP. So these patients, the children, when they are on 6-MP, they're prone for developing cytopenia. So it is important to screen for this polymorphism, and in this group of patients, the dose of the 6-MP should be reduced. And ALL is frequently a polyclonal disease, and mutations in subclone may be selected by chemotherapy and promote resistance. This include mutations like CRBB mutations that are linked to resistance to glucocorticoids, and the MT5, C2, and PRPS1 mutation that are associated with resistance to thioglutamine. So in future studies, it will be important to identify emerging mutations that are associated with resistance and explore the potential for modifying therapy to circumvent relapse. So one of the most significant challenge in ALL therapy is the need to take daily 6-MP and methotrexate for a prolonged period of time. So the available evidence suggests that there is a substantial proportion of teenagers, especially the children above 12 years, are found to be non-adherent to therapy. And it has been found that those children who are non-adherent to therapy, the risk of relapse is found to be high in this group of patients. Another unwanted side effect that significantly impacts the quality of life in children, particularly teenagers receiving ALL therapy, is osteonecrosis, seen in 5 to 10% of the patients. And girls are at more risk than boys, and this commonly affects major joints. And this can be reduced by alternate week schedule of dexamethasone during the delayed intensification. And the risk has not been found to be higher in patients who receive steroid pulses in maintenance. So cranial RT is other treatment modality which is associated with long-term side effects like neurocognitive sequelae, endocrinopathy, and secondary cancers. And preemptive cranial RT has been at present replaced with IT therapy or high-dose methotrexate. And cranial RT has been not found to have any benefit in prevention of relapse, except in patients with CNS disease diagnosis. The cranial RT reduces isolated CNS relapse, not overall survival. So without prophylactic cranial RT, the current protocols, using current protocols, CNS relapse rate has been found to be as low as 5%. So the current role of cranial RT is controversial, and all the current protocols treat more than 80% of the newly diagnosed pediatric ALL without cranial RT at present. So advancement in the diagnostic and response assessment modalities and risk-adapted intensification of treatment have been able to circumvent the high-risk status imparted by the disease biology, thereby limiting the number of stem cell transplant in CR1 in childhood ALL. But however, there is no consensus and there is no specific genetic abnormality which is an absolute indication for stem cell transplant in CR1. The reasonable candidates for stem cell transplant CR1 would be for early responders with high-risk categories like PH-ALL, EPP-ALL, or infant ALL with MLL rearrangement. Overall, around only 5 to 15% of the patients with childhood ALL are transplanted in CR1 over the different study groups. And the concern with stem cell transplant, especially with unrelated and mismatched transplant, are the TRM of around 5 to 20% and acute and late toxicity, especially associated with TBI. So most groups recommend indication for CR1 stem cell transplant based on the MRD criteria. So these are the indications according to the BFM, COG, and the Centured group. The induction failure has been found to be uniformly as the indication for transplant in CR1 in patients with ALL. And other risk categories, the transplant is indicated only if they have MRD positivity on day 53 and day 78. And in T-cell ALL, who are the people who should be transplanted? All those patients with failed induction may benefit from stem cell transplant CR1. All with end induction MRD more than 5% will benefit from CR1, but except patients who are 16 years of age with MRD negative at the end of consultation therapy. So with children below 16 years of age should be taken for stem cell transplant only if the MRD is positive even at the end of consultation therapy. So coming to minimal residual disease. So the other way of intensifying treatment or improving the survival in children is by intensifying treatment based on the early response to treatment. The early response to treatment can be measured in terms of the blast in the peripheral blood or marrow or the minimal residual disease. The minimal residual quantitation is done either at the end of injection or at the end of consultation. The end injection MRD status is more important single prognostic factor for contemporary therapy and critical for modern risk stratification and subsequent intensification therapy. And the end consolidation MRD helps in selecting patients for stem cell transplant or more therapies in first remission. So these are different trials which has shown that augmentation of chemotherapy based on the response to treatment have been found to have increased survival and increased survival. So this is based on the flow cytometry. This is from the BFM group, which has found that the people who have less than 0.1% of MRD has a better survival and less relapse risk based on the day 15 marrow MRD. And this is the PCR based MRD on day 33 and 84 marrow, which has also found that low risk MRD people have got better survival and less relapses. So the MRD response at the end of injection is the single most important outcome predictor in childhood ALL. And children who are MRD negative have much higher chance of long-term survival than those who have persistent disease that remain at the end of injection. Despite the strength of current risk classification algorithms, there are many challenges that remain. And one of the most significant challenges, if you look at the children who relapse, at least about 50% of those children who ultimately relapse fell into what we assume to be one of the most favorable risk groups. So these relapses are still occurring unpredictably. And this highlights the need for continued refinements in risk classification. So what are the available technologies for the MRD measurement? So multi-parameter flow cytometry, PCR, and the PCR method. Now with the recent method, that is the NGS, it is a promising tool for MRD, which has a high sensitivity of 10 to the power of -6. And this is patient-specific primers are not necessary in this, but however it is expensive. And this could be a new gold standard in near future. The main target for monitoring MRD in ALL is the IgG. The MRD levels in ALL tend to be 1 to 3 logs greater in bone marrow than in peripheral blood. So the optimal biological sample to measure MRD could be the bone marrow in ALL. And however, sensitivity also depends on the starting DNA input amount. This is the major limitation when analyzing samples after myelotoxic treatment. So how to improve outcomes in T-cell ALL? T-cell ALL shares some chromosome rearrangement with B-cell ALL. However, about 50% of the patients with T-cell ALL have recurrent chromosomal translocation specific to the subtype. And the most common chromosome abnormalities include rearrangement affecting the TCR regulatory elements. Of this, the translocation 7, 9, 5, 14, and Notch mutations are found to have poor prognosis. But at present, there are no prognostic clinical variable or genetic alterations other than MRD in risk categorizing pediatric ALL. So on comparing the survival of ALL patients between 2000 and 2005 and 2006 to 2010, in B-cell ALL there is no much difference in the survival between the two time periods. However, when you look at the T-cell ALL over the last decade, a 10% improvement has been found in the overall survival rate. This is mainly due to the risk-adapted intensification regimens introduced recently in the treatment of ALL. So these are the MRD-based decision on the T-cell ALL. The BFM trial, it was found that the MRD of less than 0.1% on day 78 had similar outcomes regardless of day 33 MRD. And MRD positive at day 78 had an inferior outcome. Similarly, the 7-year cumulative relapse risk was also found to be higher when the MRD was more than 0.1%. In the UK trial, the end injection MRD of 0.01, when there is a standard BFM consolidation, instead of the CAPTC escalating methotrexate with asparagine, had a 5-year event-free survival of 93%. And similarly, in ETP ALL, in the ALL clinical trial, 7.8% had M3 marrows as compared to 1.1% for non-ETP ALL. And at day 29, only 18% of the AETP had MRD less than 0.1, whereas 69% in the non-ETP had MRD less than 0.1. Despite the difference in early response, the 4-year overall survival was similar, that is 91 versus 91 in ETP and non-ETP. Thus suggesting that the post-end consolidation MRD has a better prognostic predictor in ALL, whether ETP or the non-ETP ALL. There are some recent updates in the treatment of T-cell ALL, that is the study from the COG trial, that is a phase 3 randomized trial which compared the CAPTC methotrexate plus L-asparaginase versus high-dose methotrexate with or without nelarabine. So this post-injection patients were classified as low risk, intermediate risk, and high risk based on the NCI risk group and early treatment response. And all T-cell ALL patients were randomized to receive CAPTC methotrexate versus high-dose methotrexate. And patients with intermediate risk and high risk were randomized to receive nelarabine or not. And this Capici methotrexate was found to be superior. There's a 5-year DFS and OS was found to be 99, 91, and 93 compared to 85 and 89 the high-dose methotrexate. And nelarabine was also found to have a superior disease-free survival, 4-year disease-free survival of 88 compared to 83 in the non-nelarabine group. And the Capici methotrexate with nelarabine arm had best outcome. It's a 4-year disease-free survival of 92%. And no isolated CNS relapses on Capici methotrexate or nelarabine were observed. So in North America, the Capici methotrexate regimen is recommended for all patients with T-cell AML, and in UK, Capici methotrexate for high-end induction MRD is recommended. So this is the overview of the current North American and UK AML recommendation for T-cell AML. So in the North American model, MRD more than 0.1% and consolidation should be taken for stem cell transplant. In the UK, which is after Capici, the MRD is more than 0.01% should be taken for stem cell transplant. So coming to molecular immunologically targeted therapy in ALL. The development of targeted therapy and immunotherapy in T-cell ALL has lagged a bit behind the B-cell ALL. But there are some very exciting advances in the understanding of biology of T-cell ALL in recent years. And there are several pathways that have been shown to be activated and are potentially targetable. And now there are early phase trials that are investigating BCL2 inhibitors such as venetoclax, the anti-CD38 antibody daratumumab, and CDK4/6 inhibitors such as palbociclib in children with refractory and relapsed T-cell ALL. Coming to immunotherapy, over the past decade, there have been published trials that have shown benefits of immunotherapy in many populations, children and adults with recurrent newly diagnosed disease. One agent that has been promising is the inotuzumab. It's a monoclonal antibody that directed to CD22 that is commonly expressed in leukemia and that is conjugated to a cell poison called the calicheamycin. And another agent is promising that has been promising is the blinatumomab. It's an antibody that binds to both child and adult CD3 positive T cells. That is, they bind to the normal immune system cells and simultaneously bind to the blast cells, thereby encourages the normal immune system to attack the blast cells expressing CD19. And the final drug that has been very promising has been the CAR T cells that have been transduced outside of an individual to express a receptor that will target CD19 on the blast cells. And with inotuzumab and CAR T cells, the response rate of around about 80% has been observed. This is the model of the inotuzumab ozanimod and blinatumomab CAR T cell. And this CAR T cell therapy, this process of manufacturing is shown here. This chimeric antigen receptor is similar to an autologous stem. This process is similar to autologous stem cell therapy. The T cells are collected from the child by apheresis, and then the T cells are expanded and genetically modified to express the chimeric antigen receptor construct in a manufacturing lab, and then they are administered back to the patient in a process that takes about a month to complete. So to summarize the selected developmental therapeutics in childhood ALL over the past years, the pegylated L asparaginase have got long half-life, reduced immunogenicity, liposomal vincristine which enhances target tissue delivery and decreases neurotoxicity, and it is a non-vesicant. And the other agents are nelarabine for selective for T-cell ALL, monoclonal antibodies like rituximab, inotuzumab, blinatumomab, and tyrosine kinase inhibitors in the pH positive and pH like ALL, and newer agents that have been found to potentiate chemotherapy are the bortezomib and the TK inhibitors like ruxolitinib in pH like ALL. The gene expression signature of leukemic blast can predict in vitro and in vivo chemosensitivity and treatment in future, thereby help in customizing to patients' pharmacogenomic and leukemia genotype. The targeted and immune-based treatment can replace conventional chemotherapy regimen, thereby reducing toxicity while retaining overall efficacy of treatment. Example TKI for pH negative ABL class fusions, antibodies like blinatumomab, and cellular therapy with autologous and universal CAR T cell therapy. Thank you.
So was a really super talk. And thank you so much for finishing in time and for explaining so many important aspects of treatment. The next speaker is no other than Dr. M.B. Agarwal sir, and everybody knows him, so it's really not required to give an introduction, but as part of my duties, I will do so. Professor M.B. Agarwal is professor and head of Bombay Hospital and Institute of Medical Sciences. He is president of the very active forum of the Mumbai Hematology Group. He is also consultant at Leelavati Hospital and Breach Candy Hospital. And Sir is an excellent clinician and a teacher with no match. And it is my pleasure to invite him to deliver a talk on pediatric CML.
Thank you, Dr. Tulika. When I'm doing this job of speaking on pediatric CML, I request you that in the question box, I see about 58 questions. Now, I don't think, just like last time, we will not be able to cover all 58. So I'll request you to select out about five questions for each speaker.
Absolutely.
And once again, I assure the participants that the remaining questions will be answered through email by our speakers, so that we remain within the time frame of this webinar. So pediatric CML. We will see two cases to begin with. My first case is now 16 years old. When I first saw her, that was almost a decade ago, she was a young 6-year-old girl, CML CP, moderate spleen, PCR able was 93%. She was so-called intermediate risk. Family was concealed. They chose imatinib. She had a relatively smooth course, achieved the desirable molecular response, did have some multiple bothersome niggling toxicities in the form of she got a bit waterlogged, she had fatigue, she had muscular pains, and her growth was retarded. In 2017, that is 7 years after her diagnosis, she and the family, myself, we decided that she should go for now treatment-free remission. Drug was stopped. Now she is with us for follow-up for last 3 years with molecular tests at regular intervals. There's been no molecular relapse. She is, from all angles, a cured CML. My second and the last case today is this young lady who is now 24 years old. We saw her 6 years ago. At that time, she was 18-year-old college student from Surat. She was asymptomatic and incidentally diagnosed to have CML-CP. Uterus, LOSCO, no comorbidities, father, chartered accountant, mother, architect, very strong, big family support. The plan was that she would be going abroad after about 4 years for higher education. The family was conceived and they chose nilotinib as the treatment.
If you want to.
She was put on 300 mg twice a day. After 3 months, BCR-ABL was 0.2. After about a year, BCR-ABL was non-detectable, and this was in 2015. She had no adverse events. 3 years later, that is 2018, they decided to go for TFR. After that, she moved to New Zealand for higher education. She got married last year and had a quick pregnancy, which she has been advised as well. She delivered last month. She remains in molecular response. What did we learn from these two cases? Pediatric CML is a highly treatable disease. There are more than one options with respect to TKIs. Side effect profile of TKI is manageable. Imatinib can lead to physical growth retardation. Treatment-free remission is possible and should be the goal for those who achieve sustained deep molecular response, the DMR. For younger patients, marriage and childbearing is possible. Coming to the detailed discussion, pediatric CML is a very rare disease. It accounts for 3% of leukemias in children and 5% in adolescents. At the moment, we have approximately 1,000 CML patients following up with us, and just 50 of them are in the pediatric age group if we go up to the age of 18 years. In infants, it is even rarer. Overall incidence is 1 per million children. This varies from 0.6 to 1.2, 0.6 in the first decade and 1.2 in the second decade. I would like you to note the references underneath and one name: HISIA N 2019, HISIA N 2016, HISIA N 2015. We'll come back to this later on. This is a large pediatric oncology clinic from UK, looking at the age, sex, incidence and prevalence rate in UK of CML. What you see in the histogram are the male and the female cases depicted in the blue and pink, and you see that the largest number of patients are elderly. And what we're discussing today is somewhere here. Even if you go up to the age of 19, we're discussing this part of CML today. What you see in the graph is the incidence rate per 100,000 males and females. Besides being rare, pediatric CML is a different disease. And the difference is that it's more aggressive than the standard CML of adults. How is this aggressiveness defined? Pediatric CML presents with higher WBC count, lower hemoglobin, larger size of spleen. There is a higher rate of evolution to accelerated phase in blast crisis. The adult prognostic scoring system, SOCAL and Euro, do not apply well to the pediatric CML, but what can predict the progression-free survival is the ELTS, that is UTOS long-term survival score. This is the UTOS long-term survival score in children and adolescents published in Hematologica 3 years ago in 2017. And if you look at SOCAL score, SOCAL Young score, Euro score, UTOS score, and the ELT score, the red is the high risk, the yellow is the intermediate risk, and the green is the low risk. It's only the ELTS score which significantly differentiated between these three groups. Euro score failed, SOCAL score failed, and UTOS somewhere closer. This article published years ago differentiates. This article published 5 years ago differentiates in the pattern of disease in young adults, adults and elderly. And if you look at the rates of progression to accelerated in the blast crisis, it is highest in the younger people. This is a study above age 18, but if you take 18 to 29 years, the green bar, it shows you the maximum incidence of AP and BC as against people who are above 60 and between 30 and 60 where it is much less. There are genetic differences between pediatric CML and adults, and 3 of them are listed here. Pediatric CML has additional cytogenetic abnormalities. The genomic BCR-ABL breakpoints resemble Ph positive ALL, and AXL1 mutations are more frequent. This publication 3 years ago talks about the additional cytogenetic abnormalities beyond 922 in children and adolescents. And the conclusion was, in contrast to adults, additional chromosomal abnormalities are observed at diagnosis, but they do not seem to have prognostic significance. These are various BCR-ABL breakpoints, major, minor, and the micro. This is the classical CML 210 with B3A2. That's ALL with P190 even A2. And this is the pattern more common in pediatrics, and that is what is shown over here. Coming to the treatment, and treatment of course is TKI. We have 5 of them: imatinib, dasatinib, nilotinib, bosutinib, and ponatinib. That's their chemical structure. As far as the today's discussion on pediatric CML is concerned, we will chiefly discuss only 3 on which substantial data exist, and that is imatinib, dasatinib, nilotinib. There is no data on bosutinib, and there is a small data on ponatinib, which we'll just have a look at that. So a pediatric oncologist has option, and the patient also has option: imatinib, dasatinib, and nilotinib. Like adult CML, TKIs have improved the outcome in children. Imatinib, the first generation TKI, was approved for pediatric CML 14 years ago in 2006. It has taken a long time for the second generation TKIs to get their approval as first line treatment for pediatric CML. And ultimately, 3 years ago for dasatinib and 2 years ago for nilotinib, this approval came for the first line CML. What has this done? This has pushed the allogeneic stem cell transplant in the treatment of pediatric CML to third line of treatment. That means you will at least give treatment for pediatric CML with 2 TKIs before thinking of stem cell transplant. What are the doses of these TKIs in pediatrics? Imatinib 260 mg per meter square with a ceiling at 400. Nilotinib 230 mg per meter square twice a day. Capping is at 300 mg twice a day. And dasatinib 60 mg per meter square with capping at 100 mg OD as the highest. And these are all published in 2018, 18, and 17. Dasatinib has another dose schedule, which is weight-based. So depending upon your weight, less than 20 kilo, 20 to 30, 30 to 45, and above 45, you can give a flat dose of 40, 60, 75, and 100 mg. Imatinib. So almost about a decade ago, this is the French group which showed that imatinib is effective in children in previously untreated chronic phase, published in JCO. And what it showed is that if you go from hematological response to undetectable BCR able to 4 log reduction to complete cytogenetic response to major cytogenetic response, overall these curves at the end of about 3.5 years are showing the responses which are little suboptimal than what you see in adults, confirming that pediatric CML is a little more aggressive disease. As against that, this is a recent, this year publication from China, closer to home, in Medicine by Deng et al. And what they have shown is almost over 5 years, the imatinib in pediatric CML has a survival which is a flat, straight curve. Overall survival of 95%. Moving on to dasatinib. So just 2 years ago is this publication about dasatinib in pediatric patient. Result from phase 2 trial. This is a multi-center trial from multiple centers in Europe. Conclusion was similar. The dasatinib therapy has efficacy and safety profile like adults, but for one difference. Adults develop 4 complications which were not seen commonly in pediatric, and that is pleural effusion, pericardial effusion, pulmonary edema, and pulmonary hypertension are not so common in pediatric age group. Nilotinib. So that's a very recent study in Blood 2019 by Hizia Nobuku and others, phase 2 study. And these are the results. Event-free survival in newly diagnosed pediatric CML CP, you see almost a straight line. up to the 3 years. And that's event-free survival in imatinib, dasatinib resistant or intolerant pediatric CMLs. It was slightly less than the previous one, but still excellent with 90% event-free survival by the end of 3 years. This is the same study looking at major molecular response. And if you look at the newly diagnosed patient, it reaches almost 65% by 1.5 years. And if you look at the resistant intolerant patient, it reaches almost 60% by about 1 year. There is a study published by Hizia Nobuku last year about pharmacokinetics of nilotinib in pediatric patients. Coming to the last TKI, the ponatinib. So British Journal of Hematology this year, Nobuku Hizia has presented their group experience on ponatinib in pediatric practice. This study had 12 ALL and 9 CML. With those small numbers, this is the largest published study in the pediatric CML ALL from the real-world use of ponatinib. Overall, ponatinib appears to be reasonably well tolerated in pediatric patients, especially as a single agent when you give it for CML. Obviously, we need to have further data on ponatinib to know the optimal dose from a large-term safety and activity profile. This is a Turkish article, a case report rather, of a remarkable response with ponatinib in a child with last phase of CML, showing complete molecular response. So a pediatric oncologist has to choose, probably individualize the type of TKI he will use for a given child. This was an analysis published last year that what is the choice of a pediatric hemato-oncologist with respect to TKI in 2019. And the voting was 2/3 will like to use imatinib, about 30% will like to use dasatinib, 1.5% will use nilotinib, and 2.5% were not sure or will use something else. This tells you that the longest experience of imatinib plays a big role. How do you assess the response to TKI? Clinical, hematological, cytogenetic, and we will not discuss these, and the molecular. The molecular response assessment is championed by Timothy Hughes from Brisbane, Australia. And today we talk about DMR, the deep molecular response that we are looking at. And what does that mean? A log 4 to 4.5 reduction or even more is the DMR. When you start your treatment with TKI, at 3 months, you desire a BCR level less than 10%. At 6 months, less than 1%. By 12 months, less than 0.1%. And at all these time frames, there should be minimum major molecular response, which is 0.1%. You define suboptimal response and failure. The suboptimal response is shown in yellow, and the failures are shown in red. And what you see, that a BCR level at 3 months more than 10% is failure and indicates switch to the next TKI, and so on. Between imatinib, nilotinib, and dasatinib, significant number of patients. In this, there are 3 studies, 51, 140, 44. In this, 25 patients, and in this, 84 patients. If you look at 12 months data with respect to major molecular response, it's around 30 to 40% with imatinib, and it is 50 to 60% with dasatinib and nilotinib. And you may feel that these deeper response achieved earlier with nilotinib and dasatinib may be of great value. But just 6 months and 1 year later, that is at 18 months and 24 months, if you look at the MMR with any one of the TKI, it is around 60%. And here it's around 70%. So the other drug like imatinib, which takes time, ultimately catches up with the MMR. When you're talking about pediatric CML, an extremely important issue is the compliance. It's not so much of resistance to TKI which defines the failure of suboptimal response, but it is very often the compliance. And therefore, another important job of pediatric hemato-oncologist is to see that the adherence to the treatment is maintained, which requires counseling at frequent intervals to the patient and to the parents and the guardian. Drugs do not work in patients who do not take them. Is the commonest cause of failure of treatment in CML in children. Switching to the second line TKI, you need to invariably look at the kinase domain mutation studies. And you will pick up one of the mutation in almost about 70% of cases. That means more than 2/3 of the patients. If you do not pick up these mutations in 70% of cases, then move from Senger's technique to NGS and you will pick it up. What you see in orange are the common mutation. And the deadly one is the T315I mutation. And unfortunately, the T315I mutation is common, accounting for over 20% of these mutations. It is important to pick up these mutations because these kind of graphs tell you how to select the second line TKI. In green, you have a signal that go ahead, imatinib, nilotinib, dasatinib. In yellow, you have a signal that you have to be careful, the drug may fail. And in pink, you have the signal that the drug is going to be ineffective. So imatinib is ineffective if you have these three mutations, while all three are ineffective if you have 315I mutation. In this study, almost 45% of patients, there was no mutation picked up. So there are other mechanisms of resistance. But this was by Senger's technique. NGS will definitely reduce this figure. TKIs have adverse events because of which one may be intolerant. And that's important because that itself becomes indication to switch to the second line treatment. I will not discuss individual TKI toxicity because that's a subject by itself, but this is a summary of all the toxicities. Bone marrow toxicity by all, cardiac and peripheral vascular disease by nilotinib and ponatinib, pulmonary toxicity by dasatinib, GI and hepatic toxicity by bosutinib, kidney toxicity by imatinib, skeletal-muscular pain and fatigue imatinib, dermatological toxicity by probably each one of them, immune dysfunction by dasatinib, and biochemical abnormalities by nilotinib. You need to look out for all of these, see their grade, and decide whether you need to switch, decrease the dose, or give a temporary halt. There are some unique problems with unique solutions. So these are problems unique to pediatric CML. And the first of them is effect of this TKI on growth. Second one is the effect on the bone metabolism. The third one is the effect on endocrinology, especially thyroid. The fourth was the effect on gonads. And the fifth is the effect on fertility. So if I summarize them, the TKIs have some peculiar problem in pediatric age group related to growth, altered bone metabolism, endocrinopathies, delayed puberty and impaired fertility, and teratogenicity during pregnancy. So this tells you all those 5 unique problems, and the changes are that the growth is attenuated, bone modeling is dysregulated due to altered metabolism of calcium, phosphorus, and vitamin D. Thyroid may show both hypo and hyper. There's a delayed puberty, gonadal dysfunction, and decreased fertility. And if you give them during pregnancy, there are fetal abnormalities and miscarriage. So you need to monitor height, weight, growth velocity. You may have to do DEXA scan at 6 months to 1 year intervals. Look at thyroid function periodically. Look at sexual growth by Turner staging, looking at gonadotrophins and sex hormone, and as and when needed, the pregnancy test. Management of these 5 peculiar abnormalities will be: appropriate patient will be a candidate for growth hormone supplement, bisphosphonates for the bone remodeling, hormonal replacement therapy or anti-thyroid drugs. You may do sperm preservation or fertility preservation for females and avoid TKI during pregnancy. This is an interesting study in an animal model from Germany talking about the effect of TKIs on disturbed growth hormone axis, together with clinical observation in pediatric CMLs. And what this study showed was, as the duration of imatinib therapy increases up to 250 to 300 weeks, the Z-score body height decreases. This is decline in height with imatinib treatment up to 2 years, and you can see how the growth is affected. This is change in bone metabolic parameters in children who are on imatinib with CML from Mount Sinai. There is an off-target effect of both imatinib and nilotinib in D3 metabolism, as per this publication from Canada. Looking at osteocalcin, there is a decline in the bone formation over 156 weeks. And you can also look at this urinary parameter, which speaks for bone resorption, and there is again decline. This is a study in rats, again from Europe, impact of long-term exposure of TKI imatinib on skeleton of growing rats. Coming to the issues of fertility and pregnancy. So imatinib crosses blood testicular barrier. This results in reduced sperm density, sperm count, sperm survival rates, and sperm activity. Fortunately, the sex hormone level and the structure of reproductive organs are not affected. As far as the guys are concerned, there is no increased risk of malformation or increased abortion in their spouses. And this is a study of over 200 males taking imatinib when their spouse became pregnant. Similar data exists for nilotinib and dasatinib, and I will show you all these references also. Nilotinib and dasatinib, and they are also safe when the man is taking them and the wife becomes pregnant. Of the 66 reported pregnancy outcome in the spouse, when the man was taking dasatinib, there were only 2 abortions and 1 child with syndactyly. Talking about the women and the girls, in the largest series of female patients taking imatinib, with outcome of 210 pregnancies, success rate was 60%, healthy and alive. 20% selected to terminate the pregnancy, 7% had fetal abnormalities, and 11% had spontaneous miscarriages. Another smaller study of 56 female patients taking dasatinib, 26 had miscarriage, 11 had malformations, and the rest were normal, healthy, full-term babies. On nilotinib, 50 cases of pregnancy have been reported, and 3 of them had malformations. So the advice: female partner of male CML patient with TKI on TKI have no risk whatsoever of pregnancy-related complication. They don't have to ask their husband to stop TKI when they desire pregnancy. So TKI can be continued in the male patient. For the female patient, contraception must or at least should be planned. Pregnancy can be planned. The best way is where the patient is medically fit to undergo treatment-free remission. So give a most potent TKI, achieve deep molecular response, wait for deep molecular response to be there, for at least 2 and preferably 3 years. Take the female patient off TKI and then let them go for pregnancy. In the first trimester, a woman who comes with pregnancy while TKI therapy is on, the decision has to be individualized. The patient should be offered termination and the rest is family decision. In the second and the third trimester, you should offer to stop TKI and switch to interferon or peg-interferon. If the situation warrants that the TKI must be continued and the family desires to continue TKI, the data with just 3 out of 50 malformations support nilotinib. And I promised you that I will show you the references. These are the 3 large references. By Chang, impact of imatinib on fertility of male patients with CML CP, published 3 years ago. Abruzzi, management of pregnant CML patient, published 4 years ago. And Abruzzi again, tyrosine kinase inhibitors and pregnancy, published 6 years ago. Coming to bone marrow transplant. One of the earliest articles was in 2011, just when imatinib got approval for pediatric patients. And it talks about controversies in the treatment of CML in children, understandable because TKI era for pediatric had just begun. We have a mature data now, and you have now our friend Izia Nobuku writing this article last year on biology of blood and bone marrow transplant about practice patterns of pediatricians in pediatric CML. And this is the data. 4 studies, 2003, 2009, 2010, 2014. Number of patients, significant, from 125 to 340. Disease phase for hematopoietic stem cell transplant, donor source, and lastly, the overall survival from 45% to almost 87%. That is Hizia blood 2019, Hizia blood 2016, and Hizia in PCNA 2000. Now, bone marrow transplant as the third line therapy was preferred by the pediatric hemato-oncologist in almost about 70 to 80% of cases. So, it is firmly established that today bone marrow transplant is done by pediatric hemato-oncologists as a third line therapy. TFR, and when you're talking about treatment-free remission, you cannot forget the contribution of Mahon from France. He showed a decade ago TFR of 40% on imatinib therapy. Those who had to relapse in the first 6 months, and then most of the patients, except occasional relapses, almost 40% have remained in TFR for as long as 51 months. The benefits of TFR cannot be overemphasized. TKIs have serious long-term effects in the form of recurrent pleural effusion, pulmonary hypertension, this is dasatinib, renal dysfunction, that is imatinib, vascular effect, that is nilotinib. There are lingering mild toxicity which are important for a kid: fatigue, skeletal-muscular pain, GI symptoms, skin changes, waterlogging. There are huge psychological factors of taking drug for whole life. And then there are social issues of marriage, pregnancy, and of course the cost of therapy of taking TKI from the age of 6 years to the age of 80 years. What are the requirements of stopping TKIs? A total therapy of minimum 3 years, of which 2 years should be deep molecular response. Child in the family should be willing to intensive follow-up because you need monthly BCR-ABL for the first 6 months and 2 monthly for the next 6 months and the 3 monthly for probably the rest of the life. Availability of high quality RQ-PCR, availability of result quickly, and of course, a hematologist and medical oncologist availability who should be par excellence. These are guidelines, and I will just tell you about the green. So these are the children who can go for treatment-free remission. Institutional criteria, low SOCAL score, a detectable BCR-able transcript, only chronic phase, optimal response to first-line TKI, this has changed. Even it is possible after second-line treatment. Duration of TKI therapy more than 8 years has changed to 3 to 5 years. Deep molecular response, not necessarily 4.5, but even 4 will do, and the duration of that remains 2 years. One has to remember there is something called withdrawal syndrome when you stop TKI, and that is in the form of severe skeletal-muscular pain, which can happen in 1/5 to 1/3 of children. This is the largest review article on TFR after first and second generation TKI, published in American Journal of Hematology 2 years ago. And this is talking about pediatrics, British Journal of Hematology last year, discontinuation of imatinib in children with CML with sustained DMR, results of STOP IMA-PED study. And this is a Japanese study which shows you that the discontinuation of TKI in children, 50% of children may not require TKI again. And that's results and outcome of intermittent imatinib in children and adolescents, meaning by that you want to decrease the complications like growth and bone metabolism by giving on-off imatinib therapy. So, is TFR possible in pediatric CML was published by Sudarov in Leukemia 2018 and some time ago in British Journal of Hematology. CML in children is a more aggressive disease with different biology. Outcome of TKI discontinuation in children were suboptimal in small cohorts. TKI withdrawal syndrome causing skeletal-muscular pain, there is no data in pediatrics. There is some information that neurocognitive impairment, possibly caused by rebound increase in neuronal ABL activity, is more significant in young kids. Still, reports suggest that TFR after imatinib discontinuation is possible in pediatrics who have been treated with imatinib for long term and who have durable DMR. An intermittent schedule of imatinib off and on does not seem to worsen the outcome. These encouraging results should allow more prospective studies on TFR in pediatrics. And when a group of pediatric hemato-oncologists were asked about stopping TKI, 15% agreed to stop, 29% said they will not like to stop, and 51% said that they will like to stop it as a part of clinical trial. This is Dr. Sergio, Dr. Hokus, Dr. George Cortes, who is our guest on 7th of August for a live webinar, and Dr. Neil Shah, the 4 CML giants who have worked on TKIs for the last 20 years. And that's the name I've been telling repeatedly. Professor Dr. Nobuko Hiziya, a Japanese, settled and working at Columbia University Medical Center, New York, and has done extensive work on pediatric chronic myeloid leukemia. And she will be our guest speaker for one of the forthcoming webinars. These are some of the publications on pediatric CML 2020. In Blood Journal, How I Treat Children by Nobuko Hiziya in 2019. Nobuko Hiziya 2016, Pediatric CML is a unique disease requiring different approach. This is British Journal of Hematology. Early responses do not predict outcome in children and adolescents. This is Managing Children with CML, British Journal of Hematology 2014. That's How I Treat Pediatric CML in 2012 in Blood. And then lastly, closing with Indian publications. This was the oration given by Dr. Deepak Bansal from PGI Chandigarh, Dr. ICMR Excellence Award that he was offered in September 2019 and subsequently published in Indian Journal of Pediatrics. This is a review article by senior resident Namrata Bhutani from Safdarjung Hospital, published recently. That's Dr. Samir Bakshi from AIMS, New Delhi, IGMR. in 2019 with Deepam Pushpam as the first author. Is pediatric CML really a different disease? That's from GCRI Ahmedabad, Dr. Sonia Parekh and her group. And that's from Chennai, Sri Ramachandra Medical College and Research Center. Well, I don't think I have to conclude anything. I have discussed various aspects of pediatric CML that exist today. We know that the future of pediatric CML is extremely bright, and we will be able to use the word cure for at least half of them. Well, thank you so much. And I hand over the stage now to our moderator, Dr. Tulika Sheth, for conducting the question and answer session. We can do this for about 30 minutes. Over to Dr. Tulika Sheth.
So, thank you. This was, again, an absolutely amazing overview of pediatric CML. I think I'll start with the questions to Dr. M.B. Agarwal first, and then we'll go to the questions for ALL and AML. So, thank you for the wonderful talk. The first question is a question that was posed by one of the audience members. Do you do a RQ-PCR in all of your patients at baseline?
So this has been a question asked repeatedly in the conferences with varied answers. I do it in everybody because there is enough data to show that the rate of decline in BCR-ABL, the slope, has something to tell you about what will happen after 3 months, 6 months, and 1 year. So if somebody has got a BCR-ABL at baseline of, say, 15% versus 95%, then at the end of, say, 1 month, 2 months, or 3 months, if from 15% it becomes 10%, you will be very happy if you didn't know that it was only 15%. So yes, I do it for everyone.
So thank you. Now the monitoring that we do for our pediatric CML, we don't have any special guidelines. So do you do the monitoring as per the ELN criteria?
Yes, I think it is unlikely that you will have a different guidelines very soon, or the guidelines will differ because now there are TKI for almost a decade approved for pediatric CML, and this being a relatively rare disease, you may not be able to sort of produce some controlled trials. So 3 months, 6 months, 1 year, followed by preferably every 3 months, and if not possible, every 6 months. For the rest of your life, try stopping the drug, and monitor them very closely. As I said, every month for 6 months, every 2 months for the next 6 months, and every 3 months for that month.
So that brings me to the next question. When you have a family who comes with a pediatric CML child, what are the goals of therapy that you talk about? And do the goals of therapy help you choose which TKI?
Goal of therapy in 2020 ELN guidelines are very clear. It is stoppage of the treatment, TFR. Younger the patient, more the interest. The patient who has not completed the family, more the interest. So from the today's token, we're almost totally talking about the group where if you do not look at that as the goal, you will be giving the drug for 70, 80 years.
So would you prefer second-line TKIs over first-line TKIs?
That is the question I nicely avoided when you included in the last one. I'm not sure. We know that the second generation TKI give you a quick response, deeper response, less risk of going to accelerated phase, blast crisis, and less mutation. But when it comes to overall survival, there is no difference. So cost could matter. Prediction of toxicities and a little discussion with the family, what is the toxicity of which drug could matter. Most of the pediatric patients have no comorbidity, so there is not too much of discussion that whether you have lung disease or heart disease, which we do in adults. So they're all nice, healthy children. So detecting a comorbidity is not really a criteria. So very often, at what cost the drug is available, what is the family's preference with respect to what is expected toxicity are the decision making. I don't think efficacy-wise you will be really concerned.
So in your practice, After how many years of TKI are you offering treatment-free remission, TFR?
Yes, so I will like to achieve DMR. And by definition, it is 4-log reduction. And then I will like that to be frequently monitored so that it is sustained for minimum of 2 years. If the patient is not very enthusiastic or is not compelled, I don't mind continuing for another 1, 2, 3 years, because there is data to show the longer the DMR, more the chance that the patient will have a successful TFR. So we know that 60 or 50% of children are going to again need the treatment. And we still have not been able to define those. But one of the definition is, if you have been in DMR quickly, and if you are on DMR for the longest period, then your chance of achieving TFR successfully is a bit more. So I don't push them. If they say, I'm happy, I will continue for another 1 to 3 years, fair enough, continue.
So that's wonderful. So last question, do you see BMT in the treatment of CML at all?
So to me today, it is failure of 2 TKIs. Once there is a failure of 2 TKI, we have so little data on ponatinib, plus the availability of ponatinib, plus we are still not sure what it will do to the kids as far as the cardiovascular toxicity is concerned. So after failure of any 2 TKI, I would discuss BMT with them. So it has become a very minority, because 2 TKI failing in pediatric itself is a rarity, but nothing before that.
Brilliant. Thank you so much. You've answered all of our questions. Thank you so much. So next I move to Dr. Gauri Kapoor. Dr. Gauri, we have many questions, but I'll just select a few of the questions to ask you. So is Dr. Gauri here? So,
yes, I'm here.
Wonderful. You have a very popular talk. Yes, I can hear you. So one of the questions was, what is the methodology of MRD that you are using at your center? Because you said that MRD should be done at end of induction, end of consolidation, and obviously pre-transplant. So what methodology are you using?
So we have started doing MRD only recently in the last 1 or 2 years, and we are using the flow cytometry to do the MRD. And some of the results that I shared during my presentation, especially the COG AML studies, the 0531, so their results are based on flow cytometry. So we are using flow cytometry. And those results call MRD negative as less than 0.1%. But right now what we are using is end of induction 1% or less, end of second induction less than 0.1% is satisfactory.
Okay. So another question was, there were several questions on AML with CNS disease. So can you just comment on, so one of the questions was, why do you give intrathecals if it's CNS negative? And there was another question on therapy for AML with CNS disease.
So we do know that pediatric AML, there is a significant number of children. There's a small percentage of children who have CNS disease at diagnosis, but a significant number do get CNS relapses. And with various trials, the BFM used 4 doses of triple intrathecal during first treatment. There are studies that use up to 8 intrathecals for CNS positive disease. And usually we will try to avoid cranial radiotherapy for AML. But we know there are CNS scleromas, we know there are CNS meningeal disease, especially the M2 and the M4, M5 have a higher predisposition for CNS disease in pediatrics.
There were a lot of questions on therapy and protocols. One of the very common questions was, how many doses of consolidation is ideal?
Right. So as I discussed, it has to be tailored to the molecular and genetic disease. So initially we used to give 5 cycles of chemotherapy, 2 inductions and 3 consolidations. And a lot of studies have been done There are some which show 4 are adequate or good risk, and there are others that show that there are inferior response with 4 cycles and 5 are required. So others have also shown that it depends how intensive has been your initial treatment. For example, if you are using idarubicin as induction, that is more intensive than using daunorubicin. In these cases, you could use for high-risk patients or intermediate-risk patients, you could use a mitoxantrone, an anthracycline with a cytarabine for consolidation. In the intermediate, see the good risk, you don't need more than 4 cycles. That is pretty clear. 2 induction, cytarabine donor-based, 2 high-dose ARAC consolidations. That seems to be adequate for the good risk. Now we have the intermediate and high risk. Now, if this is high risk and we are doing transplant, then the question is irrelevant. So the most important thing is the question for the intermediate risk patients, where they have shown that 5 are better, that at least 1 consolidation, that means after the 2 inductions, 1 consolidation must have an anthracycline.
Okay. There were many questions related to NGS and different mutations that are present. Do you do NGS in all of your AML patients?
So the answer to this is we do molecular tests, but we do not do NGS for each patient. We would love to do it, but very few can afford it. It's quite expensive. Because at the end of induction, you want to have all this CBPA data, etc. But we can get our 3 or 4 translocations. We can get FLT3 and we can get NPM. So routinely, I would just look for the translocations. I would send a karyotype. I would look for my common 4 translocations, and I would want to know the NPM and FLT3 data. If my patient can afford, then I would like NGS, but routinely I am not able to do NGS for every patient.
There's a question on 821 translocation in AML. Would you do c-KIT, and what is the data of c-KIT in 821 pediatric patients?
Right. So what they have shown is if c-KIT is there, the prognosis, they don't do that well. But I'm not sure there's enough data to answer the whole part, because we have seen 821 patients who relapse. But many of our patients don't have complete data on the molecular profiling. We don't have their full karyotype. Sometimes we have the good karyotype information, sometimes we don't have it. So I think we work with a lot of limitations. And in that way, I feel if the basic workup, molecular workup is not available, then MRD is very good. Because if you have an end of induction MRD which is less than 0.1%, you don't have to worry very much. You can be sure that this patient has a responsive disease.
Now, since now we're moving towards more of an adult-like regimen with only 2 drugs, there were a lot of questions on the way that you had given the Dono and the RSC, and because that's not exactly the way it is given in adults. So is this specifically because it's pediatric? You know, the days that you give the Dono, instead of giving day 1, 2, 3, you gave on alternate days.
So the pediatric protocols, I will say what we use is somewhat based on the MRC protocol. MRC and even the American protocols conventionally use 3 drugs: cytarabine, daunorubicin, etoposide, or 60G. We used to use all the 3 drugs. Now the adults use 3 plus 7. 7 is continuous infusion of cytarabine. MRC uses cytarabine as IV push. If you look at the pediatric AML data, the best results for many, many years were coming from UK. So the MRC trials had fantastic results. Their AML results were much better. If you compare them internationally, they had excellent results. And I will tell you the reason for this was that their consolidations were very impressive. They used HAM, they used CLASP, and they used amsectin during consolidation. And the toxicities were tremendous. We have tried them in few patients, but it is difficult to give that much support to every AML. And I will tell you, the patients who survive this, they have excellent long-term survival. So a lot of deaths would occur due to the treatment toxicity. This protocol has IV push cytarabine for 10 days during first induction and for 8 days during second induction. So MRC has conventionally used it. A lot of the protocols, if you see, don't have that much logic behind it. They have used it, found it to be successful. And because these children don't have comorbidities, they tolerate it very well. The elderly, older adult patients with AML have many comorbidities. Probably they cannot tolerate 10 days of cytarabine because the longer you give cytarabine, the longer it will take for myelorecovery. So their neutropenic phase will be longer, and therefore they will have more infections and complications. So I think this is just a pediatric protocol. There are 2 or 3 different variants. We use this because we were doing the MRC, so we use cytarabine for 10 days, and we still use it. We dropped the etoposide, but we used Dono plus cytarabine 10 days during induction, 8 days during second induction, and IV push. We do not use what shall I say, continuous infusion. We find it easier to handle.
Okay. So the last question I'm going to ask for AML, though there are many other questions which you'll have to answer individually later, is if you have a patient who's refractory to 2 inductions, what would you do now?
So I would try to understand why this patient has such a poor prognosis and how many blasts are there. So one would try to see if the initial workup had all the molecular FLT3 workup had been there or not. And then I would try to see if the doses of induction drugs were appropriate or not. I would try to see if there's a BCR-ABL there or a FLT3 ITT there. And then I would try to see the family as well. Refractory AML is a bad disease. Prognosis is very poor. So I would try to see whether palliation or curative intent would be decided for this patient. It would require a lot of discussion with the family.
Excellent. Thank you so much. I now have a lot of questions for Dr. Fawzia. Dr. Fawzia, I hope you're there. So, hello. So, one of the initial questions we had was if you have a bad prognosis BALL patient, but you're in a resource-constrained setting, what would you recommend for this family?
We give what we are using is a BFM protocol. So whatever protocol they are using it, if that is actually in the high risk category, start with the high risk protocol, then go the MRD assessment.
Okay. Then we have several questions on pH positive ALL. So in pH positive ALL, one of the queries is, do you do BCR-ABL monitoring and how frequently?
Yeah, we do BCR-ABL monitoring. So post-induction, we do like an MRD assessment, we do the PCR, quantitative PCR, then post-consolidation.
And in which patient would you choose second generation TKI pH positive ALL? Is there any way that you would decide whether to use first generation or second generation?
So those patients who are not having a significant response, or if the RQ-PCR is not improving, then we do the TK mutation analysis. Till now, that's what we were doing, and based on TK mutation analysis, we change it. Now we are planning to start on a dasatinib trial actually upfront for all the pediatric ALL. Now what we have been doing is
another mutation. Okay, and then another question is pH positive ALL. What is the role of pegylated L-asparaginase? So do you do pegylated L-asparaginase in induction?
We are not using it. Actually, our pediatric oncology unit is using pegylated L-asparaginase. We are using the regular one.
Okay. So MRD
methods
in ALL. Are you doing, what methods are you using for?
Flow cytometry.
Okay. And do you do NGS in all of your patients?
No, we NGS meaning for the MRD. We have not started it yet. For the risk categorization or the MRD?
I'm not sure. I think it was on MRD, the question.
NGS, MRD, we have not started yet. We are planning.
But for risk stratification, are you doing NGS?
We are not. That also, it's still in the like we are working on it. Presently for the pH-like ALL, we do the fish to look for the CRLF2, the JAK, ABL, all these mutations are looked on the fish.
So, in fact, that was the next question. So, how are you diagnosing pH-like? By the methods that you have, do you feel you're able to pick up all the pH-like ALL?
Not all the pH-like. We are not like screening them upfront. All those patients who have poor response to treatment, induction failure with persistent MRD with no pH positivity, those patients we suspect. It means like otherwise not falling into any other high risk. Those patients we suspect, and then we go ahead with the fish for all these markers.
Okay, so there are still many questions, but I think I'll just take one last question, and that is sometimes we don't get 6TG available. What is your idea on using 6MP? Is it effective?
Yeah, we replace with 6MP.
And what dose do you usually use when you replace it?
So we are using at 50 mg per meter square in the maintenance.
The conventional. Excellent. So thank you all. I think this was a wonderful opportunity, and I'll hand this back to Dr. M.B. Agarwal and the organizers. Thank you.
Sir, you're muted. Yeah, so thank you very much, Professor Tulika Singh, for conducting this